First of all, I would like to thank the Medtronic for continuous support to EBC activities all these previous several years. They really helped us and they understood the need. They also had some very important projects like Visible Heart that really helped us understand better how to treat bifurcation lesion. And it was really a pleasure to work with them and set up this symposium, 1-hour symposium on practical approaches and novel technology to optimize left main procedural outcome. We have 3 goals. One is, of course, to learn about contemporary treatment strategies for left main bifurcation lesions, but also to reflect on practical cases. Second objective is to learn from state-of-the-art imaging on stent behavior in bifurcations, including left main bifurcation. And the last objective is to learn about usefulness of novel generation DES Onyx XLV dedicated to large vessel treatment. And to set the stage, I will say a few words about selection of treatment for left main, about current guidelines and clinical aspects to be considered. Left main is frequently present on coronary angiography. 5 to 7% of patients have angiographically detected left main stenosis. And what is very important in the latest guidelines, we have need for revascularization in this patient subset, put as very important because it reduces mortality compared to medical management of these patients. And this was reflected also in the evolution of European guidelines for left main treatment. In 2010, PCI for distal left main had class 2B, and only lesion type and characteristics were mainly considered. 3 years later, in 2013, there was introduction of heart team discussion for patients with left main and multi-vessel disease treatment. And in those guidelines, in addition to lesion type, also patient risk was evaluated and was important when considering surgical or percutaneous intervention. And following SYNTAX study, update of guidelines in 2014 gave really PCI much more prominent role, because based on SYNTAX study results, left main disease with low SYNTAX score got class 1, similar to class that we have for surgical revascularization, and also intermediate SYNTAX score patients 23 to 32 got very good class 2A indication, and only patients with SYNTAX above 32 had class 3. But class 1 and class low SYNTAX score and intermediate SYNTAX score is very frequent, and 60% of left main patients are actually, based on latest guidelines, eligible for PCI. And if we stratify by SYNTAX score, we can see that patients with low SYNTAX score and patients with intermediate SYNTAX score are actually patients with either isolated left main disease or left main and 1 or 2 vessel disease. And based on this, we have designed also our EBC main study that will be also presented in this session. In that study, we will compare left main plus 2 vessel additional possible treatment, and we pled to all contributors and to all sites which started enrollment to consider each of the patients. And I really congratulate, first of all, Adrian, because he included so far the largest number of patients in this trial. Development of technology was also extremely important when we see this analysis compared with bare metal stents and first generation DES, where we were really inferior compared to CABG treatment in regards of major adverse cardiac and cerebrovascular events. Introduction of second generation DES really made our treatment non-inferior as compared to surgical revascularization, but there are still challenges to face because up to 80% of left main lesions are actually distal left main bifurcation lesions. And what is very important from different imaging modalities, we understood that 3/4 of our left main have diameters in the range of 4.0 to 5.75. So we definitely need different device to treat those lesions. And from flow dynamics, especially with contribution of our colleagues through all these years at EBC meetings, we learned about plug distribution related to hemodynamic conditions, and we also from 3D QCA learned a lot about diameters and angulation of left main, which is different from other bifurcations, and based on 3D QCA analysis, mean diameter of the left main is 85, 86 degrees, so very wide angle bifurcation. So when we consider strategy and technique selection, we need to take into account plug distribution, the size of the main and the side branch, severity and length of the side branch lesion, and that was already discussed yesterday here, bifurcation angulation. I have to add also the importance of imaging because we have to admit our voting system results from yesterday, and of course, operator experience and expertise. Provisional is probably, as long as we don't have randomized study results, the best strategy also for left main as for other bifurcation lesions, but based on current evidence, among two stent techniques, there seems to be no difference between different treatment approaches. And having said that, to go in deeper in this, it's my great pleasure to invite my teacher and friend, Dr. Yves Louvard, to speak about new technologies that may potentially impact left main bifurcation treatment. Yves, floor is yours.
Very good friend. So I don't remember if it was 2 years or 3 years ago, I visited a city called Minneapolis in northeast of USA. It was minus 17 Celsius outside. This cath lab was, the ambience was good. This cath lab is directed by Paul Iezo, you see here. And I saw in this early morning, I saw first a living heart, just explanted in the morning from a pig. And he was fibrillating like this, and you have seen that it was defibrillated, and now it can be examined with a lot of with echography, with a catheter measuring pressure in ventricles, in auricles, and also you can use angioscopy. And this is the topic I will show you, which is angioscopic visualization of bifurcation stenting. This cath lab is equipped with X-ray technology that we can use to work like in our cath lab, even if it's a quite old machine. And Paul Iezo is manipulating very well his angioscope to show what we are doing inside the vessel. So this is exactly what we can see is here penetration in the side branch towards the most distal sail. So this is a typical provisional stenting strategy. The stent was implanted across the side branch, maybe back to the beginning, to show you something is for me absolutely essential. What we see here is the shareholder. This is the carena. And it plays a very important role in the physiology of the bifurcation. So this is stent implantation. A pot has been already done. You can see the strut on the wall, and then it's very easy to enter in the most distal cell during the pullback maneuver, for example, towards the side branch, and to do the kissing balloon after pot is still my preference, pot, kissing, and pot. And this is the final result you have seen very quickly, showing a good coverage of the main vessel, the distal main vessel, and projection of metal in the side branch. A second situation is to show you here how important is to do a pot. On the left side, you can see that we have a wire. We try to go in the side branch, we see top left. And even with visual assessment, looking at the angioscopy, we were systematically crossing outside the stent, even crossing outside the stent towards the side branch. So we have observed, this is not, a phantasm. We have observed that in our group with, for example, CT scan 6 months after left main stenting, showing 2 tubes, one unstented going to the circumflex and one stented going to the LAD. On the right side, on the contrary, the stent is fully opposed, and as was showed before, is quite easy to access to the side branch toward through bigger cell, because you see here also the difference of expansion of cell towards the side branch. What I want to show you here was not mimicked really. You see the gel wire. You imagine maybe looking at bench that the gel wire is always going the straight way to the side branch. Not at all. Sometimes it's going around the stent. And I just want, showing you that, I just want you to imagine what will occur now if you find your support, guiding support, not good enough. You want to push your guiding. And at that time you try to degel the wire. You will have what we have seen 18 cases on 400 patients for left main, stent distortion, longitudinal stent distortion. It's a real danger when you are doing a provisional stenting strategy with gel wires. To show the advantage of the Medtronic stent, all the family of Medtronic stents that are rounded shape over maybe the square shape that you can see at the top in order to crossing. And I remember since the very beginning of this kind of technology, in a period in the 90s, was important to have this stent to be able to reach the most distal lesions. So first provisional stenting strategy, again, quickly, the carena I've shown. Okay, the tap now. Tap is a provisional technique, like the culotte we'll see later, but culotte is not always a provisional technique, but tap is a provisional technique. Again, the carena, the first stent, crossover. You see this is not fully deployed, so here very clearly again we have to do a pot, it was done. After the pot, exchange of wire was done, and kissing balloon, this is a kissing balloon. To do the kissing, you re-enter the distal cell again. Okay, ready for the kissing. And look at the metals which is not opposed in the side, at the ostium of the side branch. Now the kissing is pushing this metal, and you will have not only a good position in the proximal part, but also at the ostium of the side branch. This is really the fundamental aspect of the provisional stenting strategy, to be sure that you are entering the distal cell and pushing metal in the side branch. Now, if we need to do a second stenting, you can do a tap or a T. Here, a tap was done, you see, with a slight, we see the carena in the middle, here, which is a modest one. And we see with that we have a covering of the lesion, which is acceptable. You see the strut distally are smaller than the proximal ones. So this is just the culotte I will show you is also the provisional strategy. So a stent has been deployed from proximal to distal, a pot has been done to a fully opposed, and now a second stent is sent to the side branch, which has been prepared with a kissing balloon. So you see the number of steps we need for a good culotte. I think tap is necessary, and pot is absolutely necessary before the kissing. Kissing, balloon, and then implantation of a second stent. So what we do now is a mini culotte. Maybe we'll do later maybe string, even if it will be probably difficult. So you see, you don't have a complete coverage of the full proximal segment. I think this is important to limit the amount of 2 layers implantation. And after that, of course, in my opinion, you have to do a second pot to fully oppose. If you do only a single pot at the end, probably you won't be able to expand correctly the 2 layers of the stent proximally. And after that, this is followed by a kissing. And you see some protrusion here before the kissing of metal. The new carena here, because what we are facing here on the right is the main vessel. And of course, as we stent it from proximal to main, we have the wall of the stent in front of us. So we have to kiss now to remove this and build a reasonable carena shorter when we enter distal towards the distal vessel. You may have a short carena. And this is now the result. We see a single layer proximally, double layer in the proximal segment, a carena, which an amount of metal which is acceptable. So a DG crush, this is a crush technique. So you have to begin by the side branch with a slight protrusion, as you can see here. A second balloon is there to crush the stent. And I have to say that the difference versus a bench here is the aspect this crush stent has. This is probably why I don't like very much this kind of technique. But you can see that we re-enter towards the side branch not in the distal part to avoid crushing of the side branch stent inside the ostium, but in the middle. And after that, as you can see, after the first kissing, now it's fully open, and some crush is still visible on the right. A second stent now is implanted. It's fully open. So imagine next time we'll have to cross only one layer. So this is the deployment of the stent. We see the side branch ostium. Here we have to re-enter again in the middle, better. But the stent was expanded, so probably we can enter where you want. And after that, we do a final kissing as usual. And this is the result with a minimal amount of double layer here on the right for this decay crush. So my conclusion is that with this visible art, it can be a very important instrument for teaching the techniques and showing operators what they feel sometimes, what they can see, but not if it's not reconstructed, sometimes it's difficult with IVUS or OCT. They can see and keep in their mind the bench technique to think when they feel a difficulty to advance a balloon, exchange a wire, to understand what they are facing. So thank you very much for your attention.
Thank you very much, Yves. We will have discussion at the end. Next speaker is Francesco Burzotta. Francesco will speak about how stent size selection influences left main PCI.
I would like to start questioning how big is left main. Here we know very well because we are really dedicated to this kind of intervention, but it is very important to remember that when we evaluate by IVUS, we define that the IVUS reference diameter, for example, in this relatively recent study is 5.2 by plus or minus 1.3 millimeters, and this translates in the fact that statistically, this means that the vast majority of the main are in the diameter range between 3.9 and 6.5. This is an important feature because if you remember how often you use the 6 millimeter balloon in your practice, you realize that it is very conservative way, the way we used to work. And if we review the stent sizes for left main, we learned here by Nicolas Fouan that it is really important to know your stent. And he did a great job that we used in our practice, which was to over-dilating the stents and testing what is the response. However, if you look at the left main range, you see that this is the area which we had last year in 2015. And this is the area that we should cover with overexpansion of the smaller drug-eluting stent we have, according to his chart that showed that it's possible for one better from the others, or to use the large, hopefully available 4.5 or 5 millimeter dedicated drug-eluting stent. Well, we know that it is possible to overexpand, but we have also the possibility to check what companies are telling us. So if you look at the instruction for use labeling for overexpansion of this drug-eluting stent, you see that for some of the stent we have, there is no mention in the instruction for use. For some of these, there is the fact that you are allowed to do this according to them, a suggestion up to 4.5. So this means, and there is for 2 other stents the possibility to expand more, with the synergy stent the possibility to reach 5.75 that will cover for you all the left main range according to the instruction for use. Now I have the last release, which is the Onyx XL stent, which allows to cover it. So we have actually, following the instruction for use, just the selection between these 2 drug-eluting stents. And we used a lot, but we should rethink about the suitability of overexpansion during our procedures. So if we just post-dilate up to 5.75, the Resolute Onyx XL and the Synergy stent, so you will see that there is a difference in the way they expand. So at the end, you see that there is some foreshortening and some change in the stent size. So if you just measure the stent after this aggressive post-dilation, but it is in the range of large left main, you will find that average foreshortening is less than 1% against 15%, so really a huge difference. And the other point is the fact that when you overdilate, you change the structure, and this influences the stent coverage, so the mitral to artery ratio you have while post-dilating, and you have also the possibility to influence the structure of the coverage of the stent, which may influence the drug elution process. The other point is that we are dealing with the left main, which has a particularity. It is almost always, according to our techniques, a ostial lesion, because we want to stent over. And this means that we are dealing not with coronary anatomy of the vessel, but with aorta anatomy. So really stiff vessel to be opened up when we go up to the ostium. And if you compare just the Onyx or the Resolve stent with the XL stent, you will find that the radial stent, so the resistance to compression, is wider with the last release XL stent due to the fact that it is thicker. So it is a way to rethink. So we ran in the past to have thinner stent struts, but when dealing with the ostial lesion, it is probably sometimes advisable to have something which is more strong. And when we deal with isolated left main disease case like that, if this is a small to mid left main, I think that there is drug-eluting selection opportunity wide, because we may adjust with the vast majority of drug-eluting stent we have in our shelves. However, if you have a huge, large 5.2, for example, diameter left main in which you have the ostial lesion, it really should be recognized that to have this fantastic result, it is very easy using a stent which is perfectly covering everything and providing the good scaffolding all over your plaque. So, what about the left main bifurcation? So when you have a soft plaque like that, which is partially thrombosed, and it is really extending to the distal left main area, are we really convinced about which is that our technique is the best, the one that we discussed in the past years? So I treated this patient with following the EBC rules by Provisional. So at that time I had the Onyx 3.5 sizes according to the LAD. I performed the POT, kissing, and then repot. So the result was really nice. The patient was well, but I performed OCT evaluation. Before showing you something, I would like to show you what happens inside modeling. This is the technique we tested. We performed kissing balloon inflation, POT, kissing balloon inflation, and this is the result you may achieve. So what we did exactly in the bench for a case like that is to have this result. Look at what happens inside the left main in the area which was really diseased and with soft plaque. So rethink at this result. You see that there is some irregular border inside. It is not exactly in the left main the result which is expected when you have very good coverage of the plaque. And this is 3D OCT. You see that the stent structure, as in the bench test, is completely, showing that there is a lack of full coverage of the plaque. And let's see how much protrusion you may have in this gap. So I don't think that this patient has been properly, treated for her, because it was a lady disease. So, but by the way, we have the problem of coronary artery. Is it possible to extend or to rethink the possibility to use the XL stent into the left bifurcation cases? So to test this, what we did in Rome was to expand the Onyx XL stent very slow. And we realized that at 5 atmosphere, there is the full expansion of the balloon. But when you go at 12 atmosphere, you see that it increases the size. So this is the comparison by QCA of the two aspects, 5 atmospheres and 12 atmospheres. And so what we did was in the same model, we did the same test. Okay. Believe me, so we delivered a 5 atmosphere. We performed the pot and with the same stent, expanding it, and then we performed the kissing and repot. And this is the result for this. I think you may appreciate the fact that we really have been able to size the XL stent to the 2 sizes. And we also measured this by micro-CT, and it was 3.6. So this means that in the absence of plaque, at least, or after probably good preparation, if you go very slowly and you go up to 5 atmosphere, you may have 3.6 stent with this, for sure at the expenses of a lot of metal inside, so higher coverage as expected by the Onyx 3.5 into the LAD, but very good coverage for left main. So at least in very selected cases, I mean, in which there is soft plaque in the proximal part, I think that to have this in mind may be useful. Thank you for your attention.
Thank you very much, Francesco. Next speaker is Azim Latib, left main stenting in large vessels, techniques, tips and tricks, case-based approach. Azim, please.
Thank you, Karan, and thank you to EPC for inviting me, especially Medtronic, to let me present to this session. So I'll try and keep it as practical as possible, and try and show you mostly some cases of left main we've done the last few months with the Onyx stent. I think, before starting this, I think we all agree that the amount of anatomy we see with left main is really variable. And to think that we can always treat bifurcations with provisional is not always appropriate. So there will be some cases here that I show you where we thought maybe a 2-stent approach was more appropriate. And I think, as you saw in the previous presentation by Yves and Goran, I think planning a strategy is really important. And knowing exactly, based on the anatomy, which strategy you're going to use. And I'm not going to go into detail about this since this has been covered in the last few days. Essentially, for left main, provisional strategy will remain our default, and that will be what I show you the most. But there are some cases where we'll need to do a planned 2-stent technique, particularly if it's a heavy calcified side branch or severely angulated side branch with difficult recrossing, a lot of disease, or other significant side branch disease that requires treatment. So as far as the provisional approach, you saw what it looked like on the bench, as well as the visible heart, guide wires in both vessels, side branch, pre-dilatation, only if there's significant stenosis. In general, crossover stenting from the left main to the LAD, pot, kiss, and pot again. So here's a case of a patient we treated. I'm not sure, is there any way to turn down the lights that are on the screen? Can you guys see that back there? Yeah, okay. So here's a patient with a critical stenosis of the left main, but what was really impressive, and I hope you can see it, was this really big calcified plaque sitting here at the left main, distal left main, protruding into the circumflex ostium. Because the patient had really ongoing symptoms, a low ejection fraction, we planned to do rotational atherectomy, we decided to put in a balloon pump. And since the procedure was via the radial, when we got the access, we really couldn't get up with the balloon pump. I just wanted to highlight now that there are 7 French balloon pumps available that actually go up really well and are pretty effective in these kind of cases. We wouldn't have been able to get an impeller up here either. So we did a 1.5 burr towards LAD very gently because of all the calcification. Then pre-dilated with a non-compliant balloon, first distally and then proximally with 3.0, and that's the result after lesion preparation. So we treated the proximal distal LAD with a 2.75/38 Onyx, post-dilated, and then thought about what to do for this calcified circumflex before stenting across it. And so what we thought, there was a lot of calcification there, we'd try and use an angiosculp. And we've been using very successfully angiosculps at really high pressures in these very calcified lesions. So here we took a 3.0 angiosculp up to 28 atmospheres. And I think one of the advantages of angiosculp at that pressure is that it becomes an extremely non-compliant balloon. We then place the left main stent, 3.522 from the left main to LAD, making sure that we cover the left main ostium. And then after you've done that and you've done your pot, you then really need to recross into your side branch. And I think really here, to be sure that you do recross, there are a couple of really important tricks. I think the one that you saw from Eve is the importance of doing the pot. If you don't, there are cases described, and we continue to see them in meetings, where people go under the main branch stent into the circumflex and end up inadvertently crushing the circumflex. So it's to do a pot. Also, to be sure that you really don't pass under strut, it's sometimes useful to pass through the main branch stent with a curved wire. The second, the third point, and I think probably the most important, is to really make sure you use a pullback wire technique to try and cross the distal struts as much as possible, because that does result in the best amount of scaffolding. I really like this picture that Eve and Thierry have put in their latest review in JACC Intervention, which I really enjoyed, and really tells us that we really need to be careful when stenting the ostial left main. So if we have struts that are protruding, we really can damage those struts if we inappropriately use our guide catheter. So the things to be careful of is when you advance in your guide catheter, you've just done your pot. Remember that one of your guide wires is jailed. So if you try and advance the guide catheter, there's no way you can actually get the guide catheter into the ostium without damaging the struts. I think cannulating the left main without performing a pot will result in some of the stent distortion. It may occur also when you're trying to pull out your jailed guide wire after you've done a pot and kiss. Just be careful to control the guiding catheter well. And then make sure the balloon's fully deflated, any balloon, a stent balloon in the left main, before withdrawing it, because all this too can result in stent compression. Even though we may have a stent that is really resistant to longitudinal stent deformation, and it seems that the Resolute Onyx is more resistant than other stents, I think we still need to be careful to ensure we don't damage stents. So in this case, we finished the case with a pot, final kissing, and then a final pot with a 4.5 balloon. I'm not going to show you that data. So here's the final results. We ended up being provisional on that very calcified ostial circumflex just using an angioscalp, and I think the end result is pretty acceptable. So even in some what seems to be a pretty calcified and complex bifurcation, you can end up finishing with provisional. Here's another case, a patient previously treated on the circumflex with 2 BVS and a metal stent of the ostium of the circumflex, now needed treatment of this very calcified long LAD involving the left main, and you can see here all the calcium on OCT. So in this case, we'd use a laser because we're concerned about distal embolization, a very long lesion, and then prepare the lesion with a non-compliant balloon. And here, after treating the mid and distal LAD with 2 34mm Onyx, we then treated the left main with a 4.0 by 18 Onyx and then did a kissing balloon. And we thought our kissing balloon was pretty effective. It was a 4.0 in the main branch and a 3.0 in the side branch. And we thought we could have actually ended up the procedure there. But it's interesting when you do imaging to really check your final result, you always learn something. And despite what we thought was a very effective kissing inflation, you notice how the left main stent here is completely malopposed. It's really not touching. You can see the struts over here really floating in this large left main. So I think, as has been said before, when you're going to do large left mains, you really do need to end with a pot again. I think it really is mandatory in these large left mains, and it really does make sure that you overlyze again, that you circularize your stent, and that you really oppose it well. And here's the final result in that patient. I think also we see a lot of complex left mains, and when you want to wire these, I think we need to remember that this is thanks to Francesco, this picture, that you do need to use some pullback wiring techniques and reverse wiring techniques. Here was a patient where we almost considered not doing the procedure because they had a very curved circumflex. You can see the angulation here is over 90 degrees. And I think in these kind of cases, having a reverse wire with a curve is really essential and important in trying to wire these cases. So here's the final result after a DK crush, which was very good. There are still some bifurcations where you start with a provisional approach here, a very complex bifurcation, a patient with a low ejection fraction. We did rotablade on both branches. We then did a provisional approach with a pot. We ended up with a pot with our stent towards the LAD, but the final result really on the circumflex was not acceptable, and so we ended up with a tap. And I think for the left main, this has really been our best technique to cross over from provisional stenting to double stenting. So yeah, I'll just show you the final result on that case. I'll probably finish with this case. This was a case where we did quite recently. A patient with 70% stenosis of the ostium of the LAD in circumflex involving the distal left main, a Benita 111. And we actually talked quite a lot whether we should enroll this patient in EBC. And if you looked at the criteria for EBC, the patient probably did fit all the criteria. I have to admit and be honest that I was quite hesitant. When I first saw this case, I thought, well, I think I'm going to need 2 stents. And I got to give credit to Alaida, who was sitting in the front row, because she said, well, you know, it fits all the criteria, so we should enroll this patient. We should make sure that as we do EBC main, we're not selecting patients and creating a selection bias of patients that we convince will do well with 1 stent only. So we enrolled this patient in EBC main. I'll show you what happened. This is after we wired the LAD in the intermediate, and just no matter how hard I tried with every wire I had, I just could not get into the circumflex. It was just really a very angulated, calcified circumflex. And this is how it ended up. I completely occluded the circumflex, trying to wire it. Patient, as you can see now, needs a balloon pump. He's a lot more sicker, but that's what we deal with in the real world when trying to deal with complex bifurcations. Fortunately, we were able to rewire it, used a much stiffer wire, and with a microcatheter confirmed that I could get into that I was in true lumen, and then proceeded to treat this. This is after pre-dilatation. You notice that there's a dissection there. I'm now, even though this patient was randomized to the provisional group, I'm now committed to doing 2 stents because they ease the dissection in this left main. So this is what the final result looked like after 3 Onyx stents. We did a culotte, I think a really acceptable final result, and will probably be one of the crossover cases in the EBC study. Just finally, I think there are a number of bifurcations that require some complex techniques. I think here's a patient where I think it's hard to say that in this left main bifurcation you're going to end up being provisional. It's a patient with really diffuse disease and occlusion of the LAD. And in this case, you really need to take your time and be prepared to treat the bifurcation with 2 stents, which is what we did here. We first treated the LAD, then treated the circumflex, left the left main for last, and in the end, I'll just show you the final result. This is what it looked like after reconstructing the left main with a double kissing crush, which was pretty effective with 4 Onyx stents. And again, finishing the procedure with imaging to really make sure you had the best possible result. So I think maybe in conclusion, I think you need to plan your strategy beforehand and try to keep it as simple as possible. Larger bifurcations are possibly easier, but are less tolerant to errors. The provisional remains the default approach. I think with the TAP as a crossover, elective double stenting still required in some very complex bifurcations. As far as the choice of the bifurcation technique, you saw from Goran, there's really no data to say in left main one's better than the other, and so you should use what you're comfortable with. And I think IVUS and imaging, intracoronary imaging is essential to really guide these procedures. Thank you.
Thank you very much, Azim. This was excellent introduction to our final speaker, our co-PI in the EBC main, Dr. Alaida Kiev, who will present design and current status.
So, dear Goran, dear colleagues, it's a pleasure for me to introduce you again the EBC main trial. So, just a reminder, even if this is European Bifurcation Club and theoretically all of you should be familiar with the study, EBC is the European Bifurcation Club left main coronary study, and it is the first randomized clinical trial evaluating 1 versus 2 stent in the specific subset of left main true bifurcation lesion, because so far there is no randomized clinical trial, but all the evidence that we have is from mostly retrospective registries. We already published the design of the study in Aero Intervention, and I'd like to be thankful to Professor Sorayos, who gave us the possibility to publish the design of the study. The hypothesis is that left main coronary bifurcation lesion, and we are talking about true bifurcation with both LAD and CX with a diameter more than 2.75, are best treated with the planned provisional stent strategy, and this is the belief of European Bifurcation Club, as compared to a planned dual stent strategy, and with respect to the composite endpoint of death, TLR, and myocardial infarction at 1 year. Inclusion criteria clearly is the presence of a true bifurcation lesion in the distal left main with a significant stenosis, plus the presence of ischemic symptoms, or the presence of ischemia testing positive, but also there are criteria with functional significance by FFR, or also it is accepted as a criteria in IVUS left main area less than 6 square millimeters. Left main diameter less than 5.75 millimeter, because the study is sponsored by European Bifurcation Club, but there is a grant by Medtronic, and so the study stent, as you will see later on, is Resolute Onyx, and it's already said that the Resolute Onyx come also in 4.5 and 5, so this is why the diameter, it can be 5.75, because you can postulate up to this dimension according to distraction IFU of the stent. True bifurcation lesion, as I said, 111 or 011, both branches has to be more than 2.75. It has to be clearly an unprotected left main, and clearly patient more than 18-year-old. Exclusion is the presence of ST elevation MI in the 72-hour preceding, cardiogenic shock, clearly chronic total occlusion. If you are going to have other 2 coronary lesions treated in the same time, you can treat another vessel, but not more than 1. Scinta score to be treated for the planned lesion must not be more than 32, trifurcation are excluded, and all the criteria of exclusion are normally randomized clinical trial. Study design, this is a multi-center prospective randomized 450 patients in 20 centers were planned. You have to say that at the present time only 14 centers are active out of 20. The stent to be used, as I was saying, was zotarolimos eluting stent, so Resolute Onyx. It comes also with 4.5 and 5.0 diameter, and as I was saying, by IFU, the maximum stent inner diameter is 5.75. This is why this was the kind of diameter that could have been enrolled in the study. Clearly, the study was funded by Medtronic, and this is one of the reasons why the study stent is Resolute Onyx. However, as it was presented by the prior presenters, the structure of this stent is particularly suitable for this kind of anatomy. So the group of European Bifurcation Club decided to have this study stent. 450 patients, again, randomized to planned single stent strategy or planned dual stent strategy. Clearly, you have always the possibility to do a crossover, as Azim did. I mean, this is quite open in the protocol, because this is left to the operator decision, but clearly a case like Azim, when you have an occlusion of the circumflex dissection, I think that most of us would have switched for a two-stent approach. Endpoints, the primary endpoint is a composite endpoint of that MI and TLR at 12 months. Secondary are the single component of the endpoint plus stent thrombosis, that MI TLR at 3 and 5 years. So 5 years of follow-up is going to be performed in this patient. And then there are procedural endpoints like procedural success in hospital MACE, procedural duration, fluoroscopy, diameter, and cost that has to be taken into account in such complex procedures. The techniques that are used are the techniques that have been suggested by European Bifurcation Consensus, provisional side branch stenting, as it was described by the prior speaker, and the two stent techniques that were chosen were straight culotte and decay mini crush. Why that? Because these are the techniques that not in left main setting or decay mini crush also in left main setting demonstrated to be superior to other technique. One stent randomization, so I will show you, I mean, I have to say that we were quite meticulous, and we tried really to enter all suitable patients in the trial, as Azim showed you. Sometimes we have some discussion, but at the end our belief is really, I mean, when you are in doubt, one is it's 1 or 2 stents, and when they fill in these criteria, we should really randomize. We should not be scared of randomization, always because you have always time to change and to cross over from 1 versus 2. So I strongly encourage all the centers that are in this trial to screen, but to try to enter all the patients fulfilling these criteria in the trial, because only for randomized clinical trial, you will have a clear answer on which is the optimal stenting strategy. So this was an 85-year-old female that was transferred from a referral from another hospital. She entered in the other hospital in pulmonary edema. Left ventricular fraction, when she came to our attention, was 40%. I mean, no matter what, this kind of patient in my center is not even discussed with the surgeon. 85 entering with the pulmonary edema, this is indication in our center for PCI. And this is the coronary angiogram showing a true bifurcation in the left main. This is really an 111. I mean, even if she's so old and she's a female, actually, her coronary artery looks pretty nice. And interesting, this is a bifurcation lady because she had also another 111 lesion in the circumflex and obtuse marginal. So by the protocol, I treated before the bifurcation with 6 OM, and then I treated bifurcation of the left main. A radial approach, because we mostly do radial in our lab, lesion preparation, provisional stenting, following the rules, and final kissing balloon inflation. So opening of the sideman with non-compliant, final kissing balloon inflation, and this was the end. As you can see, there is still some residual stenosis on the circumflex. I did an IVUS. I felt quite confident about the result, and for me, this was not an indication to go to 2-stent approach, because there is no flow limiting. I mean, the lesion is pretty stable. There is no dissection. So for me, this was not a crossover, and I kept the provisional approach. 2-stent approach, 62-year-old patient. Actually, this was a low-risk patient, but it was referred to us again from another hospital because he strongly refused CABG. And this is his coronary tree, looking much worse than the 85-year-old lady, so 111 lesion. Again, radial approach. The patient was randomized to 2-stent approach. And we decided to do, in this case, a culotte, so wiring of both branches, predilatation of the side branch, stent deployment on the LED Resolute 3.026, then the second stent in a culotte way, Onyx 3016, final kissing balloon inflation. And this is the final result that was checked also by IVUS. So where are we now with the study? And I think this is the weak point of all the story, and I think we have, as a group, to push the enrollment of this study. As you can see, the amount of patients enrolled was quite low, and this is quite disappointing. And here are listed all the centers that are enrolling. I think that we can do much better than this. And if there are centers that are not in the trial and feel that they have a higher prevalence of disease of patient transferred from other centers, please let us know, because I think that we have to struggle the trial and to try really to include all the patients coming to our lab with this disease and enter in the study. Thanks for your attention.